Lisa is a patient of Dr. John Colby, a respiratory specialist who's a consultant at Green Lane and Auckland City Hospital.
Hello, Lisa.
Hi.
He's also a professor at Auckland University's Department of Medicine.
Good. Yeah,
I think it
very
was
well.
in 1994 that I saw my first patient who had LAM. Now, I understand that you've recently returned from an overseas trip.
I did.
Since that time, I have seen about 5 or 6 other patients with the condition. And it was uneventful from a medical point of
It
view?
was, yes. Came back in one piece.
Good, good. And how did you
Lisa
manage
was
the
diagnosed with lymphangioliomyomatosis in 1997 when she was 29, 6 years after her first symptoms.
Overall.
Good. Most patients with LAM will be young or middle-aged women, and they will present with shortness of breath. The general practitioner will do spirometry, and that will show an obstructive pattern. And so the initial diagnosis might be that of asthma, but it will be unusual, and in particular will not respond typically to asthma therapy. If their course is atypical, if their presentation is atypical, if they don't respond to asthma therapy in the way that they should, then those are the people that you would refer to a respiratory physician for another opinion. Any other respiratory problems since I've last seen you?
No, been pretty good. Got through the beginning of winter without a cold.
The other way that LAM can present is with a pneumothorax. So obviously a pneumothorax in a young, middle-aged woman, particularly recurrent pneumothoraces or pneumothoraces that affect both sides, either simultaneously or sequentially. That should raise a number of possibilities in the mind of the clinician, and one of those possibilities is LAM. So Lisa, I've got your lung function test results from earlier today.
Yep.
When we compare those with the results of 3 months ago, there hasn't been any changes that we would regard as significant. However, that small change is consistent with a slow and steady decline in your lung function that we've seen over the last few years. The features that we look for in the lung function test is firstly evidence of airflow obstruction, particularly a reduction in the FEV1, a disproportionate reduction in FEV1 when compared with forced vital capacity. And also characteristically, there is evidence of hyperinflation of static lung volumes and also a reduction in the diffusing capacity, that is a low DLCO.
When Lisa first began seeing Dr. Colby, there was no effective treatment, and most patients were expected to die within 5 to 10 years, unlike now.
In recent years, there have been tremendous advances in the management of LAM. And as a result of a number of important landmark studies, the drug sirolimus, also known as rapamycin, is now used for many women who have LAM. However, like all drug therapy, you have to balance the risks of the therapy against the benefits. Now, how much sirolimus have you got left?
Not much. I've got it here actually.
Lisa's been on sirolimus for 5 years. She has regular reviews to supervise her treatment to make sure adverse effects aren't occurring and to monitor the progress of the disease.
That requires consultation with the patient, examination of the patient, serial lung function testing, and sometimes repeat CT scans of the chest or imaging of any kidney tumours which may be present. There you are, Lisa.
Thank you very much.
The occurrence of lymphangioliomyomatosis is said to be approximately 5 per million. It's estimated that more than 250,000 women worldwide are unaware they have the rare lung disease.